Hi, good morning, everyone. Welcome to our weekly session on CMAAO, International Weekly Meeting. We meet over here for a common topic. The purpose is to educate the doctors and the general public on the social media about what's going on in the world and get connected with the medical industry. Today we have Dr. Aviral Roy. He's a system director for critical care medicine. He's a medical consultant with over 8 years of experience providing comprehensive and evidence-based critical illness. He is the system director, critical care service for Carepoint Health in USA, New Jersey. To talk about he he is ARDS management basic guidelines. Sir, over to you.
Thank you, Dr. Agarwal. And just confirming if everybody can see me and hear me clearly.
Absolutely.
Perfect. And thank you so much to CMAAO, that is the Consortium of Medical Associations of Asia and Oceania, for this wonderful opportunity. I'll try to keep it's a complex topic, but I'll try to keep it something that's basic. So something that's understandable to the non-practitioner of critical care, as well as the general public. And hopefully it won't be too difficult. With that going ahead, there we go. Okay, we can then. So I did my fellowship I did my residency, that is from internal medicine from Marshall University in West Virginia. And then I did a fellowship from the Cooper Medical School of Rowan University. And one of my areas of interest and focus is ARDS, as especially with mechanical circulatory support. That is the use of using circulation to help assist with profound hypoxic respiratory failure. So we'll be going through the various stages of ARDS and the treatments for the various stages. What are we going to do? We're going to go through the review of basics of ARDS, our options to treatment, the guidelines, and some preventive markers that help to prognosticate your patients. So I'm sure all of us, at sooner or later in our practice, have seen this scenario. You have a 45-year-old male with 6 days of fever and worsening shortness of breath, who was being initially observed in the wards. Respiratory viral panel was done, which was suggestive of H3N2 influenza. They were started on appropriate medical management. Patient has worsening shortness of breath and tachypnea, heart rate, respiratory rate of 44 per minute. Saturation is 74% on 10 liters, non-rebreather. You get a chest X-ray, it kind of looks like this. Severe bilateral infiltrates, low lung volumes. And you're trying to figure out what to do next. Do you intubate them, put them on tidal volume with high PEEP, low tidal volume with high PEEP, high tidal volume and low PEEP? Do you intubate them and paralyze them? Do you intubate them and do prone positioning? Do you go to ECMO? What do you exactly do? And I'm here to help you answer as many of these questions as possible. So we could do a quick review of basics. This is basic lung physiology. To go over quickly, this is the inside of your lung. It is called the intra-alveolar pressure. This is the same as atmospheric pressure, or whatever your lung is connected to. So if you're connected to a ventilator, whatever the ventilator pressure, that is the same as your intra-alveolar pressure. This space is called the intrapleural space, and the pressure over here is called the intrapleural pressure. This is dictated by many things. It could be the size and thickness of the chest wall. It could be the activity of the muscles of the chest wall, so the diaphragm over here and the intercostal muscles over here. And the difference in the pressure between these two is called the transpulmonary pressure. And this is the pressure which helps you either take a breath in, which is called inspiration, or if it's and expiration, which is breathing out. So moving to that. So normally, how do we breathe? When we start breathing, or our alveolar pressure is 0 because you're connected to the atmosphere. So that's 0. The difference in pressure is 0. And because your pleural cavity is opening, you have a negative pressure over here. So you have a slight increase in pressure, in your transpulmonary pressure. That's the pressure gradient between the intraalveolar pressure and the intrapleural pressure. So there's a gradient there, and air enters the lung. Now, the important thing being, you see this when you're in mechanical ventilation, even if you have a stiff chest wall, you might have very, very high intra-alveolar pressures. But if you have correspondingly high intrapleural pressure as well, then as long as the transpulmonary pressures are not high, you really don't get any form of lung injury. Lung injury, or even for that matter, if you're playing a wind instrument like a trumpet or a trombone or a saxophone, you might have very, very high intra-alveolar pressures, but as long as your intrapleural pressure is also high, your transpulmonary pressures do not increase a lot, and doesn't really matter that much to the lung. You get into issues when you have high intra-alveolar pressure. That is when you are on, say, BiPAP or some sort of non-invasive ventilation, or maybe you're just working really hard to breathe, and we're having very, very high intrapleural pressure, high, a lot of activity over here. So over here, if you have a markedly negative intrapleural pressure, the transpulmonary pressure, as you can see over here, really gets very, very high. Sorry?
Just go ahead.
Okay, going ahead. So it's when your transpulmonary pressures get high, this is what leads to lung injury. And I'm just showing you the basics over here so that we'll remember this as we move on in the future. Then we come to the Berlin criteria, which is the very definition of ARDS. So what do you need? You need three things. You need the timing of the insult. It has to be acute. So within 1 week of a known clinical insult or new or worsening respiratory symptoms, you do need to have chest imaging, which is bilateral opacities, not explained by effusions, lobar or lung collapse or lung nodules, and the origin of edema. Respiratory failure not explained by cardiac failure or fluid overload. In other words, you should have non-cardiogenic pulmonary edema. So if you have less than 1 week of bilateral infiltrates that is not cardiac in origin, then you would have ARDS. And fourth, but most important, you need to have hypoxemia. How much hypoxemia? Your PF ratio should be less than 300 with a PEEP of at least 5. So you can have PEEP or CPAP of at least 5. So mild is 300 to 200, moderate is 200 to 100, and severe is anything less than 100 PF ratio. What is PF ratio? PF ratio is PaO2. So that is when you get your ABG, the partial pressure of oxygen in the artery, in the arterial blood, divided by the FiO2. So for example, if your PO2 is, say, 80, and if you're requiring 80% FiO2, you will you'll do the calculation of 80 divided by 0.8. You measure the FiO2 in not in percentage term, but as, so 80% will be 0.8, 90% is 0.9. So example, 80 PaO2 divided by 0.8 FiO2 will give you 100, which make it severe ARDS. This is just a quick example of how to calculate PF ratio. Coming to hypoxemia. What causes hypoxia? Any one of these processes can cause it, and very often it's a combination of processes or one leading to another. You can get a bacterial infection, causes alveolar damage, capillary damage, leakage of fluid and edema. Inflammatory markers come in, you results in VQ mismatch. You can have some atelectasis, decreased thoracic compliance, increased dead space, hypoxic vasoconstriction, and all of these factors will work together to cause hypoxia. So these are the various factors that can cause hypoxia. And we'll just go here. So we will talk, so these factors will cause hypoxemia, and we will now look at how this can happen. So ARDS goes through 3 phases of disease. The first phase is the exudative phase, lasts about 7 days. This is when your lung is pouring, the damaged lung is just pouring in exudate or what edematous fluid or proteinaceous filled fluid with inflammatory cells into the alveolar space, trying to resolve the infection. Proliferative phase is as the lung tries to recover from that infection. And if the lung cannot recover it within 21 days, then you start to go into the fibrotic phase, where this is just a complication of the ARDS. So what happens? You have the insult, either direct or indirect, activation of inflammatory cells and mediators, which results in damage of the alveolar capillary membrane, increased permeability of the alveolar capillary membrane. What happens? Your plasma then leaks into the alveoli, resulting in edema fluid and inflammatory cells into the air spaces. You get dysfunction of surfactant, and as a result of which your lung cannot work anymore. You can't remove oxygen across the alveolar membrane. This is a good schematic diagram of what it would look like. So this is what a normal lung alveoli looks like. And you can see it's one layer, it's a one cell thick layer alveolar membrane. It's a thin basement membrane over here and one single endothelial layer thick capillary over here. So this is very, very thin and air comes in and air exchange happens quite readily. Whereas over here, once you have any sort of injury, you've got the sloughing off of the bronchial epithelium due to whatever injury from bacteria, virus, fungus, gastric contents, ARDS, near drowning, water filling the lungs. You get all of these inflammatory markers such as TNF alpha, interleukin 1 beta, IL-6, IL-8, releasing all of these factors from neutrophils, causing surfactant injury, neutrophil mediated endothelial damage. So what happens? You've got edematous plasma filling into the alveolar membrane coming from the endothelium. You got endothelial dysfunction, and you also got this thickening of the basement membrane. Now remember, gas exchange depends on the thickness of the is that inversely proportional to the thickness of the membrane. You have water over here, so gas basically stuck here. It cannot come anywhere beyond this. So all of these factors will result in hypoxemia. Then you go through the proliferative phase where the cells of the alveolar lining start to proliferate and try to repair the damage. So that you have the AECs2, you have the M1 macrophages, you have neutrophils. What are these trying to do? They're trying to reestablish the bronchial epithelium. They're trying to reestablish the alveolar tight junctions, and they're going to try to reestablish the endothelium over here, as well as the basement membrane. However, if this process fails due to repeated persistent damage to the lung, then you move into the fibrotic phase, where there's extensive damage to the basement membrane. So what instead happens is you get this fibrosis in the interstitium of the lung. And as you can see, this is a membrane that just does not work. You get obliteration of the capillaries, you get fibroblast proliferation, there's fibrosis over here, there's persistent fluid collection in the lung, and this is what's called fibrotic phase of ARDS. So what are the various options with management? Do we have to go to mechanical ventilation straight away? No, and that's a simple answer. There are various options that are available. This is what's called non-invasive ventilation, that is without putting an ET tube or an endotracheal tube. You can use venti mask over here. You can use a non-rebreather mask over here, and you also have the option to go with high flow oxygen. This is a quick cartoon to kind of show you how to go through the various phases of ARDS. So this is a PF ratio and the intensity of intervention. When you have mild ARDS, 300 to 200, you could of course put them on ventilation, but you also have non-invasive ventilation over here. That is, you could use high flow, you could use BiPAP, you could use CPAP, you could use venti mask, whatever you want. If you do decide to go for intubation, normally when they are mild to slightly moderate, you use a low PEEP table. But as it gets worse, you can go to a higher PEEP table with low tidal volume ventilation. So everybody gets this. And as the ARDS gets worse, that's your PF ratio is less than 150, then you start adding things like neuromuscular blockade, prone positioning. HFNSO was an option a few years ago. It is no longer done because it has a higher mortality rate. A certain percentage of patients can try to undergo ECOR, that is extracorporeal CO2 removal. We won't talk about that much because unfortunately the technology has not panned out well. It has a lot of complications and the mortality rate, and there just wasn't sufficient mortality improvement. And finally, we'll do a quick look at what ECMO is, which is extracorporeal membrane oxygenation, which for the lack of a better term is an artificial lung that directly oxygenates the blood. So what's our escalation pathway for non-ventilator options? That is non-mechanical ventilation. So you can use a regular nasal cannula, 1 to 6 liters per minute. This allows you to do chest physiotherapy. You can do your deep breathing exercise for your patient as tolerated, and you want to try to ensure maximum aeration of the lung as possible. You then go to the Venti mask. It uses Venturi effect. What is Venturi effect? Whenever oxygen is, whenever any sort of gas or fluid is flowing, it reduces the pressure in there. So what happens is atmospheric air then goes in as well. And using that technique, you can titrate the FiO2 to about 40 to 60%. But you can only give up to 10 to 12 liters of oxygen with this. Then you can go to a non-rebreather mask that is anywhere from 10 to 15 liters per minute. But just be warned, do not give it less than 8 to 10 liters per minute, because these masks depend on flow of oxygen to get rid of CO2 that's collecting in the mask. Otherwise, you can just get CO2 narcosis. And finally, you can go to something like high flow nasal oxygen, which can give as high as 100% FiO2 with up to 60 liters per minute of flow. So, especially in patients with a lot of demand, that is, they're working very hard to breathe, this is a good option because it also provides a little bit of mild positive pressure airway effect, especially if they're breathing through their nose and you can keep their mouth closed. Consider a trial of self-proning if the patient will tolerate it. It's very difficult to do because, very rarely will you get the patients to lie flat on their stomach. And sometimes their body habits may not even allow it, even if we want to and even if they agree. Then we come to mechanical ventilation options. So non-invasive, remember, non-invasive mechanical ventilation is still mechanical ventilation. You're still using a machine to help assist the patient with breathing. Over here, we have two types. CPAP, which is continuous positive airway pressure. It is good as for hypoxia. It has no ventilation assist. What does this mean? It does not help in getting air in and out of the lung. It is just pressurizing the entire lung system. What does this pressure in the lung alveoli do? It helps to push that water which might collect in the lung back into the bloodstream. And of course, you get BiPAP, or BPAP, which is bi-level positive airway pressure. In this, it supports both the hypoxia, so that's low oxygen, and it gives you ventilation assistance, which means it helps you move air in and out of the lung. So it is good for helping patients who have increased work of breathing and patients who are having what's a moderate level of hypoxia. If you have patients who are concerned that they might be very infectious, especially during the COVID pandemic, if you are having an influenza outbreak, patient has RSV, you can use non-invasive mechanical ventilation with dual limb circuit with HME filters to, I won't say avoid, but to minimize aerosol generation. Of course, there's always some leakage around the mask and you just can't help that. So this was the Renovate trial that just now came out last month in JAMA. This was comparing the efficacy of high flow nasal oxygen versus BiPAP in patients with acute respiratory failure. To cut a long story short, there's no difference in outcomes. However, they did say that you need to do some more studies, especially in patients with COPD and patients immunocompromised lung, just because they had very, very low numbers in immunocompromised patients. And in patients with COPD, there's a little bit of concern that, not concern, there's a little bit of a signal that maybe BiPAP would have been slightly better. But again, because they were insufficiently powered in that subgroup, they said we probably need to do that another study with a close look at that. But however, the long story short, both high flow oxygen and non-invasive ventilation in acute respiratory failure were non-inferior to each other, and they both had the same rate of progression to mechanical ventilation. What's an escalation strategy you might use? So you have diagnosed a patient with ARDS. They're breathing spontaneously. What does spontaneous breathing mean? They're breathing by themselves. They're not paralyzed. If the patient has any one of the following: the hemodynamically unstable, renal failure, reduced level of consciousness, FRPF ratio less than 150, respiratory distress, intubate. They're not candidates for non-invasive stuff. Just intubate them and we'll see what to do with them. But however, if they're mild ARDS with PF ratio less than 300, you go to high flow. More than 300, you do oxygen therapy with nasal cannula, with venti mask, and then you reassess them. If they worsen, you do high flow. Now, depending on how they're doing on high flow, you then see what to do. If they're still in moderate distress, then you can go from high flow to non-invasive, because remember, this will give them a little bit of assistance with ventilation as well. Sometimes they're oxygenating okay on high flow, but they're just getting tired. So in that case, you might want to escalate them to a BiPAP or a CPAP, usually BiPAP. But again, if they deteriorate hemodynamic instability, neurological status, where they're not able to stay awake, that is a direct contraindication to using BiPAP mode, or worsening of hypoxia to a PF ratio less than 150. You're going to need to intubate them because you need to give them a lot of PEEP. Okay. And then not after you, when you're in non-invasive ventilation, more or less the same thing. As you can see over here, the end result is always endotracheal intubation on the left side if they're worsening, and if they're better, try to continue the same therapy, and if they're improving, try to de-escalate as tolerated. When you're intubating the patients, it's very important to have certain strategies, because this is the one of the most critical phases of the patient. You have to make sure everything is ready. You don't want to be preparing as you're intubating. Prep the scene from before. You want to pre-oxygenate your patient. What does this mean? Give them as much oxygen as you can give them, whether it's BPAP, CPAP, non-rebreather, high flow, nasal cannula, because the moment you sedate and or paralyze them, their oxygen level will rapidly drop. Try to use rapid sequence intubation where possible. Apneic oxygenation is very important over here. What does apneic oxygenation mean? It means even during the process of intubation, make sure they're running a high flow, make sure you're running the nasal cannula simultaneously, so oxygen is going into the lungs. It will give you maybe an extra 30-40 seconds of oxygenation. So especially if you're stuck with a patient with a difficult airway, or you're struggling to get the tube in, this is potentially life-saving. Now, also on these patients, be prepared for severe hypotension when you sedate or paralyze them, because you take away the respiratory drive. So be ready with push-dose vasopressors. So what are some modified intubation in special cases? So for the highly infectious patients, COVID-19, influenza, do not do conscious sedation or wake intubation. You want to go with paralyzing them, because you do not want them, spewing out aerosol particles into the room. Use your most experienced operator with maximum first pass success. This is not somebody you want to train the students on. Use a video laryngoscope to try to maximize the distance from the mouth of the patient to the face of the operator. For patients who are in distress or in extremis, you want to be ready for rapid hypotension PEA. Up to 20% of patients in this cohort will have a peri-intubation code. Patients who are high risk for coding or having a peri-intubation arrest are patients with a high shock index. Shock index is heart rate divided by blood pressure or systolic blood pressure. If heart rate, the simple way is, if heart rate is higher than systolic blood pressure, they have a positive shock index. The higher the shock index, the higher the chance they're going to code. Elderly, severe hypoxia, high BMI, hypotension on presentation, and use of succinylcholine as paralytic are all associated with a higher rate of patient coding. Be prepared with push dose vasopressor. What is this? This is a quick shot of vasopressor that you can give to the patient if you're not already hanging, or they're not already on a vasopressor drip, such as norepinephrine or epinephrine. What I like to use is 1 milligram of epinephrine diluted in 10 cc's of normal saline. So roughly each 1 ml is 0.1 milligram of epinephrine, and you can push it in 1 cc aliquots. So coming to mechanical ventilation, there are two strategies that we can follow. When you have ARDS with high compliance, what does high compliance mean? It means you're in the early stage of the disease and the lung has not gotten very stiff yet. So the lung can you can still easily ventilate the lung. But however, these patients are very hypoxic. In these patients, you might want to use a low PEEP, a high FiO2 strategy. You can probably give them a high minute ventilation, because their problem is in such patients, they tend to have more dead space ventilation, and they're usually associated with a loss of a lot of hypoxic vasoconstriction. and maybe even some microthrombi in the capillaries. When you look at the X-ray, the X-ray does not look very bad, but the hypoxia is very out of proportion to the X-ray findings. This is commonly seen in the early stages of viral pneumonia. Very often, this condition will progress to what's called low compliance ARDS or traditional ARDS. Over here, you're going with a traditional high PEEP strategy. Keep the FiO2 neat titrated to keep a saturation of around 88 to 92%. So classical ARDS management, you want low tidal volume ventilation, avoid a driving pressure. What is driving pressure? It is plateau pressure minus PEEP. You want to keep it less than 14, and you want to keep target tidal volume of less than 6 ml per kg ideal body weight. This is your classical typical ARDS, usually seen in bacterial pneumonias, aspiration pneumonia, ILD exacerbation, pancreatitis, trauma, drowning, etc. So how do we do? So we're looking over here. You always initiate mechanical ventilation where about 6 ml per kg ideal body weight, assuming they have no severe metabolic acidosis. If they do, you have to modify for that. But you want to start over here. You want to try to keep plateau pressure less than 30. You want to titrate PEEP, and we'll show you later over here how to titrate PEEP. Prevent excessive hypercapnia. It is okay. However, remember we do permissive hypotension, permissive hypercapnia. So what you can do is you can allow in my practice at least, I'm okay with a pH of around 7.25 to 7.3. Our goal is not to normalize the ABG. Our goal is to keep the ABG in a range where we do as little damage to the lung as possible and try to keep the patient alive. As PF ratio over here, as the ARDS gets more and more severe, as we can see, you might need to give higher levels of PEEP. Every time you change the PEEP, check the patient saturation. Only increase the PEEP if it improves the saturation. If the saturation is not improving, don't bother. If PF ratio is less than 150, consider prone positioning, neuromuscular blockade, and if it drops to less than, it says 80 here, I am already having this discussion. If it's less than 100, we then start to discuss VV ECMO. Now, this is why understanding the ventilator mechanics and ventilator loops is so important. This is a classical pressure volume loop. Pressure is on the x-axis, volume is on the y-axis. Now, this pressure is the pressure where you set your PEEP. PEEP stands for positive end expiratory pressure. It is the minimum pressure that the patient's lung will experience during the respiratory cycle. That's inspiration and expiration. So this is the inspiratory limb. This will be the expiratory limb on this pressure volume loop. So as air goes in, we will see that eventually there comes an upper inflection point where even for a minimal increase in volume going into the lung, there's a sudden increase in pressure. This part is a sudden increase in pressure from low volume increase. This is the upper inflection point. This is where your alveoli are getting over distended. And then, so how do you know what this will look like? This looks like a penguin beak. You can see this beak over here, like a bird beak. If you see this, it's indicating that you are over-ventilating. You're giving too much volume to the patient and you're causing over-distension. This point is your peak airway pressure. The maximum volume is your tidal volume over here. Now, as the patient breathes out, you see it's a nice straight line, and then you will come to this lower inflection point. This is where even a small change in volume is causing a big drop in pressure. This is where you have some zone for potential alveolar recruitment. What is alveolar recruitment? Maybe there's some alveoli over here that are opening and closing with every cycle. And this is where you can increase your PEEP somewhere in this range to ensure that your patient, as far as possible, is in the optimal zone over here. And you want to keep the tidal, you want to keep the volume in between in this zone to prevent atelectotrauma from repeated opening and closing of the alveoli from this end, and barotrauma or volume trauma from repeated alveolar overdistension. And that is your main mechanism of damage to the lung during mechanical ventilation. So why is this so important? We think we have a big lung, but really you don't. When you have ARDS, you have this baby lung. So little look of this entire lung, only this is what is currently active on this side. So if you give them a normal tidal volume, whatever 500, 600 ml, you can cause this over distension. And when you get this much over distension of the lung, this part, it looks okay, but it's going to cause severe damage to the lung later on. Just because of repeated opening, closing of that lung at that high pressure is going to cause the lung to leak. And this will cause severe worsening of the ARDS. So this is a PEEP table taken from the ARDS net trial. There's a low PEEP table and there's a high PEEP table. But honestly speaking, you want to titrate the PEEP in such a way, you use the PEEP that gives you the lowest driving pressure. And what is driving pressure? Driving pressure is the difference between plateau pressure and PEEP. Use the PEEP that gives you the lowest driving pressure and maintains the saturation of your patient above 88 to 92%. Anything in the 88 to 92% is absolutely fine for your patient with ARDS. They are not trying to run a marathon. They are just trying to keep them alive on the ventilator. So 88% is fine. Don't worry about it. Follow standard of care, low tidal volume ventilation, 6 ml versus 8 ml ideal body weight. You will decrease the mortality by 9%. Prone positioning, as per the Proceva trial, which was released in 2013 in New England Journal of Medicine, you reduce the mortality 17%. Paralytics in severe ARDS, using my atrocurium infusion for up to 48 hours in severe ARDS in patients who are dysynchronous with the ventilator, means they're fighting the ventilator, they're constantly alarming, having high pressure alarms, they're not getting the tidal volume properly. In these patients, you will see a 9% decrease in mortality. And if you keep your patient euvolemic, that means you prevent too much volume infusion. And if they're volume overloaded, you get rid of that extra volume on them. You can decrease the duration of mechanical ventilation by up to 3 to 4 days. This is prone positioning. So this is the same lung with severe ARDS in supine position. And then you go ahead and prone it. Why do you prone? Remember, blood likes to flow with gravity. So when the heart is pumping, most of the blood is going here, some was over here, and the least is going here. So you will get a VQ mismatch. Blood, no air. Medium blood, medium air. No blood, only air. So when you want to oxygenate a patient, you want the blood going where there is air, and you want less blood going where there is no air. So you go ahead and prone your patient. Now what will happen? Patient has air, patient has blood. Medium air, medium blood. No air, less blood. So this helps to correct your VQ mismatch, and as a result of which you will have higher levels of oxygenation. Again, same thing that's happening over here, changes in regional compliance. Why? Because what is happening is earlier in this part of the lung where there was no air and only blood supply, now you have air and blood. Okay. So as a result of that, you have an improvement of VQ mismatch. This is the same slide where the circle is the air and this line is your blood supply. So as you can see, when you have now maximized the blood supply over here and the amount of air that the patient's lung is getting appropriately. Also, what happens is you reduce the weight of the heart sitting and compressing the lung when you're supine, but when you're prone, that same heart is now sitting on your sternum and it causes less compression on the lung. This is called shape matching. So over here, this is your lung and this is your chest wall. And this is what happens is over here, when you're supine, the bottom part of the lung is maximally compressed. But when you're able to prone the patient, then bottom part of the lung opens up and more of the lung is open and available for gas exchange. And as you can see, most of your lung is located posteriorly Anteriorly, you'd have less lung tissue. So when you prone the patient, more lung opens up and is available for air exchange. So this leads to the dilemma that most patients that most clinicians are trying to do when they are ventilating their patients. How do you maximize lung function? So that's the open lung strategy, where you want to prevent opening and closing of the alveoli. At the same time, you want to try to rest the lung as much as possible so that the lung can heal. Remember, nobody runs on an injured ankle, right? You can't run a marathon on an injured ankle. For that matter, you can't even walk on an injured ankle. You want to rest it. So, but the lung is a completely vital organ. So you have to figure out a nice medium where you can rest the lung enough so it can heal, but at the same time you want to keep it open enough so that you don't get atelectode trauma. Because rest strategy causes atelectode trauma. Open lung strategy causes over distension. So you have to find a good medium in between that you can to balance out the risks from both sides. And then as you have worsening hypoxia, suppose your patients, you don't want to go to ECMO, you don't even maybe even have ECMO in your facility. What do you do? There are certain strategies such as airway pressure release ventilation or bi-level, depending on what type of ventilator you have. This is a type of inverse ratio ventilation. It's more advanced. Your staff need to understand what is going on and they need to be able to comfortable with this mode, your respiratory therapists. What it allows you to do, it allows you to minimize airway trauma. How is that? It allows you to keep a very high level of average airway pressure and a short duration of expiration and inspiration. But however, you cannot do this mode if you also have associated bronchospasm. Then this mode will not work. The other thing that you want to do for refractory hypoxia, if you're doing everything right, the X-ray looks better, but the patient's hypoxia is not improving, you want to rule out PE, pulmonary embolism, especially if there's more high dead space ventilation. What is dead space ventilation? It means air is going in, blood, that area of the lung is not receiving any blood, or at least not participating in gas exchange. So what you might want to do, you want to do a serial D-dimer assay. If you see a sudden spike in D-dimer, have a high degree of suspicion for, maybe pulmonary microthrombi or a big PE. And of course, you can get a CTP, pulmonary angiogram, to look for the PE. So this is airway pressure release ventilation. What do you see this? You keep high average airway pressure and then you do a quick release to maybe 0 or 5 of PEEP, and then you turn the lung back up. So what happens over here is the lung is always pressurized. Okay, this is an opposition to what this is what normal pressure control ventilation would look like. Not pressure, sorry, volume control ventilation would look like. And as you can see over here, because you have higher mean airway pressure, your alveoli are going to be open for a longer duration of time, and you can reduce the atelectode trauma. So what's the next option? Inhale nitric oxide. And by the time you get to this, your patient's usually already looking like this. They're on a ventilator, they're prone, they're paralyzed, and then you're driving inhaled nitric oxide through the system. And what is inhaled nitric oxide? Remember, when you have a VQ mismatch, say this lung like over here has pneumonia, what will happen is you get vasoconstriction over here. So the body tries to normalize the VQ mismatch. What it does is it'll try to send blood to the good lung or to the good parts of the lung and say no point sending blood over here to the bad lung. Because this is just shunting. What is a shunt? A shunt is when blood goes and comes out without getting oxygenated because there's no air over here. Why we give not nitric oxide? The nitric oxide helps to further improve the VQ mismatch. What does it do? It's a vasodilator. It's also a bronchodilator, but it's also vasodilator. That's what we're giving it for. So we give nitric oxide. It causes increased vasodilation of this good blood vessel and helps to further drive more blood into the side of the lung that is getting air. So that helps to reduce your VQ mismatch. So why even do drive? Why do ECMO? The reason that we do ECMO is from these studies which show that as you increase driving pressure, which is the difference between the plateau pressure and the PEEP, every 7 centimeter of water increase in driving pressure is associated with a 41% increase in mortality. What does that mean? The lower you can do your driving pressure, the more likely it is that your patient is going to survive. So if you have severe ARDS, severe PF rate with a PF ratio of less than 100, then maybe their lung needs complete rest. You cannot use that lung at all. So this is the Eolia trial results over here, which basically showed a 35% mortality in early ECMO versus 46% mortality in people who had conventional therapy. But remember this, some of them were so bad that it was considered unethical for them not to receive ECMO. So about 35 patients who were basically dying crossed over and received VV ECMO. Correct? So in people who got early ECMO, there was 35% mortality rate and 46% who got late, basically no ECMO or late ECMO. But if you add these 35 patients who are basically dead, then you can go from 57 plus 35. What is that? Almost 92. So then you would have had a 92 on 125 patients. So this is of 7, or if without ECMO, this would have been a 70% mortality rate group over here. So that's what ECMO provides for you. And who are the people who went on ECMO? People with a PF ratio of less than 50 for more than 3 hours, or less than 80 for more than 6 hours, or people who are unable to oxygenate, or sorry, unable to ventilate. How do we check ventilation? People with a pH less than 7.25, or a PaCO2 of more than 60 for at least 6 hours. And so these people got ECMO, and the control arm did the best evidence-based practice for ARDS which we have, which includes lung protective ventilation, keeping tidal volume less than 6 ml per kg ideal body weight, and a plateau pressure target less than 30. They all got neuromuscular blockade, and they all got prone positioning. Finally, what are some of the predictors for outcomes? So poor predictive prognostic markers are male sex, patients with pre-existing respiratory disease just because they have such poor pulmonary reserve. If you have a high initial requirement of FiO2, which implies severe disease from the very beginning. Patients, of course, with renal disease, liver disease, alcoholism, pre-existing heart disease. Poor functional status at baseline, again, have poor respiratory and physiological reserves. Patients with age more than 65 years, and patients who present early on with very, very high inflammatory markers such as D-dimer, IL-6, cytokines, LDH, and ferritin. These patients also have poor prognosis. So summary, figure out what type of phenotype of ARDS a patient have. Not all patients need mechanical ventilation straight away. Usually the problem is not ventilation, but oxygenation, at least initially in the disease. Multiple non-invasive options exist for the treatment of ARDS and hypoxemia. However, if the patient is failing non-invasive ventilation, it is better to fail early than to fail late. That is, if you think they're not looking good, better to intubate early than intubate late. Follow the guidelines for optimizing your outcomes as far as possible. But also remember, prognosis and family counseling is key. You have to update the family that, ARDS is not a good disease process. And even with best treatment right now, mortality rates are still for severe ARDS, like as you saw, without ECMO, is as high as 40 to 50%, in some cases even 75%. With that, I'll take any questions, queries, and remarks. Thank you.
Thank you, Dr. Aviral Roy. It was an excellent presentation, and the forum is now open for question answers. If anybody has questions, please go ahead and ask. I do have some questions related to the topic from the general public, which I will ask, but let's go ahead with the forum questions right now.
Dr. Saurabh, can I ask the question?
Yes, Dr. Bukhari, please go ahead.
Thank you. Thank you. Thank you, Dr. Aviral. Very nice presentation and brainstorming. Especially we saw all these problems during the COVID time. Can I ask some other question other than your presentation? What is the role of lung transplantation?
They tried doing the lung transplantation in severe acute ARDS with people who are just not coming off ECMO, or it didn't go well. I think survival was 5%.
Oh,
I think 1 out of 20, which is practically, so it's not done anymore. The trouble is there's just too much fibrosis. There's just too much inflammation. And what
mm,
happens is these patients are not optimized. Remember, these patients would have been on the ventilator for 20, 30, 40, 50, 60, 80, 100, 120 days. And they don't have any functional status. So you can go and replace the lung, but the rest of the body is also fallen off. So I think lung transplant for acute ARDS is not something that is being acutely looked after. It's not like acute liver failure. Remember, the acute liver failure, they were absolutely fine till the liver failed, right? So they still have good other organs. The heart is good, the kidneys are good, the livers are, apart from the liver, they've got good muscle strength, they've got good brain function. Whereas in ARDS, they've been on the ventilator, they've been getting steroids. God knows how many antibiotics they've gotten, whether they have whether they have other infections that have come and gone. So they have what we call bad protoplasm. So the lung transplant for acute ARDS has gone away now. I'll have to look
uh,
it up, I'll be honest. But the
but
last
I
time I
think
checked, it's no longer
yes,
done.
but I think they are trying in the future. Another question related to the your subject is most of your study you have quoted the before the COVID time. Is there any study recent about of this one indicating any update about the fibrotic lung disease when fibrosis, third or fourth stage, most of the patients in the COVID developed fibrosis. Is there any hope for them?
So again, depends a lot on so you're right. So one of not new things has been going on for some time now, and we saw it as a part of the Meduri protocol and other protocols, is that steroids, which were earlier not, they didn't want to give steroids earlier in ARDS pneumonia, that has gone away now. Steroids have become a part of regular treatment of bacterial pneumonias, and we can give steroids earlier now. We saw this in COVID especially, where giving steroids early on was associated with a significant decrease in mortality. And this is because the steroid helps, to ameliorate or to attenuate the severe immune response that can lead to fibrotic phase of ARDS. As far as treatment of the fibrotic phase of ARDS, we have tried multiple drugs, perfenidone, baricitinib. None of them have really worked out in the sense that to prevent progression to fibrotic phase of ARDS. And again, once you develop fibrotic phase of ARDS, depending upon the patient, if they're younger age group patient, more active, more physically active, they have a better chance of resolution of their lung as compared to somebody with multiple comorbidities. So again, multiple factors exist, but yes, just because they develop fibrotic ARDS, I've seen many, many patients recover, and to the point where even after severe fibrosis initially post-COVID, their follow-up CT scans 2, 3, 4 years later show almost complete resolution of the lung. Now, whether they
Thank
have
you.
microscopic fibrosis, which you need a PFT to pick up on, that is separate, but at least it disappears from CT scan.
Why the male pure predictor, you told me? But most of the death we saw in the females, why the male are poor predictor?
I'm not 100% sure why that is, sir. I'll have to look into why males, but I'm not talking about pure only COVID. I'm just saying regular ARDS. Uh, Usually males tend to develop a more
Severe as
a
compared to
severe inflammatory
early.
response, a more dysfunctional inflammatory response as opposed to females. So that's one of the theories of why males probably do have worse outcomes. Also, elderly males usually tend to have more heart disease, diabetes, lung disease, and that could also be a confounding factor over there. But usually males also have developed a more severe immune response.
Thank you so much. Thank you so much, Saurabh.
Uh, Anyone else has a question? So there is one question which is there, which came on my thing is, what are the potential complications for mechanical ventilation in ARD patients, and what is the survival rate?
So, as we discussed over there, the main complication for mechanical ventilation, so there are three of them, and they're all kind of codependent on each other. We have three names for them, but they're more or less the same thing. One or similar things. One is atelectotrauma. Atelectotrauma is basically, think of your lung as a big balloon. And if you take a balloon and you keep blowing it and emptying it and blowing it and emptying it, sooner or later, the substance of the balloon fails. That is, the rubber just fails. It just breaks and blows up. So that's what atelectotrauma is, from repeated or opening, closing, opening, closing, opening, closing of the balloon. So that can cause worse lung injury. So that's called atelectotrauma. The second one is what's called barotrauma. Barotrauma is a lot of pressure within the lung due to high PEEP or ventilator settings, or maybe even high volume. So what is when you have high barotrauma? If it basically, if the pressure in the lung exceeds the, remember, this is not normal lung. This is highly damaged lung. It's got a bacterial infection. It's got a viral infection going on. There's inflammatory markers. So it's the substance, the strength of the lung is reduced and is compromised. On top of that, you're putting positive pressure in. Remember, the lung usually drives negative pressure. So you're putting positive pressure in the lung. So if you have put too much pressure, once again, the lung starts to leak. The substance of the lung starts to break down. You have increased inflammation in the lung. So this is called barotrauma. And lastly, volume trauma, which is similar, usually associated with barotrauma. But usually volume trauma is over distension of the lung. So if say the alveoli has a limit of 1 ml and you fill it with 3 ml, it is over distended. So all the tight junctions have gone, all the, it's expanded beyond capacity. So it's not getting blood supply, it's getting inflamed, it's getting irritated. So that is called volume trauma. How does this manifest? Pneumothorax. So the lung basically starts to leak air out into the pleural cavity. Increased capillary permeability. So the alveoli starts leaking and the interstitial fluid, that's the extracellular fluid, and the plasma from the capillary starts leaking into the lungs. Increased inflammatory markers, and also increased fibrosis, where if the lung, the fibroblasts and the proliferator cells and the macrophages are going, okay, there's too much pressure coming in, we need to strengthen the lung, so it just starts laying down more basement membrane, and then that causes lung fibrosis.
Thank you. What are the chances of having a hospital-acquired infection on the basis of just the ventilator? And what are the chances if the ventilator is not working? Like, what stage do you guys decide that ventilator needs to be removed? And is it a cure to the thing, or it is just a support channel?
First question, chances of getting infection, that is completely dependent on the infection control policies that you have in your ICU and how strict you are with them, right? So are you doing good pulmonary toileting? That is, are you constantly doing the suctioning of the endotracheal tube? Are you doing mouth washing? Are you keeping the head of bed at least 30 degrees above? Correct. Then are you minimizing the number of times the ventilator circuit is opened or closed? Do you have open circuit? Do you have an open circuit suction system, or do you have a closed circuit suction system? So these are things which can help to determine minimizing the duration of mechanical ventilation. So are you waking up the patient every day? Are you seeing that can they be removing the mechanical ventilation as soon as possible? So for that, you do what is called a liberation bundle, the A, B, C, D, E, F, I think. So you do daily awakening trials. You do daily spontaneous breathing trials. You do daily neurological exams. you optimize the ventilator. You try to make the patient euvolemic as far as possible. You try to dry the vent out. The only treatment is to get them off the ventilator as soon as possible, because you're right. Sooner or later, they will the process. You will fail and you will have an infection. So the treatment is really how good is your infection control practices and how good is your liberation or removal from mechanical ventilation. As to when do you get rid of the ventilator, when you said if the patient is ready to come off the ventilator, you remove the ventilator. You don't say ventilation has failed, because if you remove the ventilator without giving them another way of to oxygenate to support them, they will die.
So I think this is the questions from our side. Dr. Aziz says, excellent presentation. I'm sorry we have to leave. So a lot of doctors are here. And Saturday we were discussing that, it's a because it's no longer a COVID and, a lot of people are seeing the patients. So this presentation is live on YouTube and a lot of social media. If you guys want to see that presentation, please go ahead and search the link. With this note, Dr. Akhtar, you want to say something before we leave? Okay. So with this note, I think, Dr. Aviral, we would like to thank you for your time and your knowledge you shared on our platform. It clears a lot of our doubts. And I think with this note, we would like to thank you and take a leave for your valuable time. So thank you here. Thank you so much for joining us. And with this note, we'll take a leave and see you guys for the next session. Thank you so much.
Thank you, Dr. Agarwal. Thank you to all the doctors who joined, and thank you, Consortium of Medical Associations of Asia and Oceania. I hope you all have a great weekend.
Same to you.